the year 2001. By 1st of March 2020, we performed 270 cases. By that time, we had been faced by the COVID pandemic. We needed to implement telemedicine, communicating with our patients by virtual means, and 7 cases of COVID were confirmed during the follow-up period. And by the 26th of August 2020, we resumed our program again. And by the time this presentation was done, 5 cases have been transplanted. We knew that we are facing a great challenge because the high mortality in hepatic patients with COVID was well known, specifically in those patients with higher levels of ALT, reduced platelet counts, and reduced albumin levels. For this reason, we aimed at patient safety, and in order to maintain the standard of care for our patients, we decided to minimize outpatient contacts and to promote contacting our patient by telemedicine. And for patients who needed hospitalization, we should do our best to avoid nosocomial infections. Our decision was to close the post-liver transplant clinic and to communicate by phone with our patients while our meeting would be all virtually. The preventive measures were highly emphasized, and liver transplantation was restricted to urgent groups such as acute on top of chronic fulminant hepatitis, HCC, in certain circumstances. For procedures, example for endoscopy, GI bleeding and cholangitis were the only indications for endoscopy. And we started to stratify the risk of bleeding in our patients on the waiting list by platelet count and Baveno criteria, which are non-invasive ways. Liver biopsy was almost not allowed, except in very restricted conditions of very high liver enzymes and an unknown diagnosis, or when there is a hepatic mass, and the biopsy will differ in the management protocol of this lesion. By the end of April, this easel position paper was there, and we found ourselves really on proper track. Besides that, they emphasized important points such as the vaccination, as well as prophylaxis against spontaneous peritonitis and hepatic encephalopathy. And also they included the recommendation that we should test for COVID in any patient with liver cirrhosis who acutely decompensates. They also recommended admission of patients with HCC if they develop COVID. So what we did, that we changed our strategy in management of liver transplantation by adding these 4 important points to our previous decisions. EASL consideration was also how to manage patients in decompensated cirrhosis. They recommend the usual way as we usually treat ascites, spontaneous bacterial peritonitis, and other illnesses. In HCC, we have to postpone treatment as much as we can, whether it's local regional therapy or immune checkpoint inhibitor, or is it a kinase inhibitor. For liver transplantation patients, the most important point emphasized was to manipulate, reduce, or stop immunosuppression in severe cases. However, in mild, moderate cases, this should be considered case by case. During follow-up, 7 of our patients were confirmed to have COVID. Most of them, all of them were males, aged from 47 to 68. The time of transplantation was variable. The graft status was also variable. 2 of them had new onset diabetes and 1 had hypertension. Immune suppression was FK in all of them, FK and MFN5, and 1 of these patients received triple immune suppression, including everolimus beside FK and MMF. In patients with COVID, the symptoms was mainly fever. The second most frequent symptom was myalgia, and the average duration of symptoms ranged from 7 to 21 days. Patients were diagnosed by PCR as well as characteristic CT findings. The laboratory data didn't show anything specific to those patients apart from the higher levels of bilirubin and the higher level of ferritin were associated with poorer outcomes of patients. 60% of our patients were mild, about 40 were moderate to severe. Oxygen was needed in 2 of our patients. 1 needed ventilation. Unfortunately, this was the patient who passed. We applied the protocol of management by the Ministry of Health, supported by our colleagues from the COVID team. Immunosuppression was changed in the 2 most severe cases. In the milder case, we had to reduce the dose of immunosuppression starting by MMF. However, in the more severe case, we had to start by reducing, ending up by discontinuation of treatment. When we decided to resume by the 26th of August 2020, our plan was to only transplant 1 case every 3 weeks to give a better opportunity and chance. And infection control measures were revised, and we gave a lot of lectures to the team to apply infection control measures. First 3 cases were transplanted. The case number 1 and case number 2, unfortunately, were hit by COVID. How did we manage these cases? The 3rd case was fine and was discharged on time. How did we manage these cases? First of all, room isolation. The best thing is to isolate in a negative pressure room, which we didn't have. We isolated our patient in a single room with door shut. Strict personal protective measures, and of course, contact with health worker was so much restricted. We didn't modify antibiotics, and we didn't have to modify any immune suppression. The patients went through smooth recovery and were discharged on the scheduled time. We were happy. We felt confident. And we felt we did a good job. We didn't know that frustration was just ahead. When we transplanted case number 4, was a male patient, 30 years old, with hepatitis B decompensated cirrhosis and BEL 28. The patient 1 month ago had COVID before transplantation. He was treated and he had 3 negative PCRs and he had a clear CT chest. Chest consultation approved liver transplantation. Intraoperatively, he received blood, platelets, and Simulect. Unfortunately, the first post-operative day he started to desaturate. On the 2nd day, his CT showed extensive pulmonary infiltrates. Chest consultation recommended bronchoalveolar lavage. At that time, PCR was negative. He needed CPAP on the 4th day, and he received a 2nd dose of Simulect. Unfortunately, he progressively passed into respiratory failure, needed mechanical ventilation. Unfortunately, he passed away, leaving us with the differential diagnosis of drug-induced lung injury, transfusion-related acute lung injury, ARDS, or infection, and whether COVID could have a definite role. We decided to continue, and we had to struggle and avoid frustration, and we decided to go through the case number 5. Was a male patient with hepatitis B, and his MELD was 16. He had a multicentric HCC. The patient was transplanted on the 13th of January, and then he passed through the various courses which we see during post-transplantation. First, he developed fever, proved some ground glass appearance. He had a suspicious COVID. PCR was negative by that time. Then he developed a rejection, followed by some pulmonary infiltrates, and later on he developed a collection. The patient is doing well now. This is Abir, by the way, following the patient sonographically, and we are expecting this patient to be discharged soon. So my conclusive remarks are that the chance of liver transplant patients to be infected with COVID may be high. High risk seem to be in early post-operative days. Mortality is the same or maybe lower because it seems that immunosuppression may be protective. Modification in immunosuppression is not always needed. MMF may need to be discontinued or modified according to the condition. Age and male gender were associated with poorer outcomes. A final important conclusive remark is that we need to learn more about outcome of liver transplantation in cirrhotic patients with a history of COVID. By this, I would like to thank you all and wish you a very pleasant, fruitful day. Thank you.